Pneumatosis cystoides intestinalis with pneumoperitoneum. Introduction. Pneumatosis cystoides intestinalis or PCI with an unknown etiology is an uncommon disease characterized by the presence of multiple gas-filled cysts within the submucosa or subserosa of the intestinal wall. The patients are often prone to misdiagnosis or mistreatment. Diagnosis of PCI is based on plain radiography or endoscopy. Multi-detector computed tomography provides data on other intra-abdominal pathologies. Therefore, it is an important modality for the diagnosis of PCI.
This is the right hemicolon of an asymptomatic 54-year-old man presenting for his first screening colonoscopy. As a surprising incidental finding, we see these bulky cysts within the colonic wall. As you can see here, there are both small solitary cysts and complex large bulky cysts. The lesions arise in completely normal-looking mucosa and are covered by regular mucosa. In this case, the cysts are predominantly located in the right hemicolon, and there are only a few cysts in the distal parts of the colon. What we see here is the characteristic macroscopic appearance of Pneumatosis cystoides intestinalis within the colon. This is an unusual condition characterized by gas-filled cysts that are located within the serosa or submucosa. Typically, the cysts are surrounded by regular and non-inflamed mucosa. This feature is very important because it allows clear differentiation from the linear form of pneumatosis that is the result of bacterial invasion of the colon wall in necrotizing colitis. This is a completely different, life-threatening scenario. Pneumatosis is a rare finding, but it is important to be aware of it because these lesions are easily mistaken for submucosal tumors and inadequate therapy might be initiated. Indeed, it is not uncommon that these patients are referred for surgery or endoscopic resection of these lesions. This should be omitted because invasive therapy is rarely indicated. How can we prove that indeed these lesions are filled with gas? To prove it, the cysts are punctured with an injection needle and the air is aspirated. Immediately, the cysts collapse and the diagnosis is established. In asymptomatic cases like this, no therapy for Pneumatosis cystoides intestinalis is required.
Clinical manifestations. The incidence of PCI is unknown. Symptoms, if any, are usually secondary to an underlying disease. Non-specific symptoms such as abdominal discomfort, diarrhea, constipation, rectal bleeding, tenesmus, or weight loss, and severe complications including volvulus, intestinal obstruction, tension pneumoperitoneum, bleeding, intussusception, and intestinal perforation may be seen. Pneumoperitoneum and pneumoretroperitoneum can be rare complications due to rupture of the cyst. Treatment. Conservative approaches include nasogastric decompression, intestinal rest, antibiotic therapy, and oxygen are recommended for patients with positive examination findings and normal biochemical parameters who are confirmed radiologically and to have no intestinal ischemia or perforation. An urgent laparotomy is necessary in cases of intestinal ischemia, obstruction, intestinal bleeding, or peritonitis. Definite surgery should be performed during laparotomy if necrosis, perforation, or marked ischemia is observed in the intestine, as in our patient.
Pneumatosis intestinalis is pneumatosis of an intestine, that is, gas cysts in the bowel wall. As a radiological sign, it is highly suggestive of necrotizing enterocolitis. This is in contrast to gas in the intestinal lumen. In newborns, pneumatosis intestinalis is considered diagnostic for necrotizing enterocolitis, and the air is produced by bacteria in the bowel wall. The pathogenesis of pneumatosis intestinalis is poorly understood and is likely multifactorial. PI itself is not a disease, but rather a clinical sign. In some cases, PI is an incidental finding, whereas in others, it portends a life-threatening intra-abdominal condition. References.
In conclusion, the correct diagnosis and management of PCI is based on the results of clinical assessments and imaging techniques. PCI also should be kept in mind as a rare cause of pneumoperitoneum. Concordantly, it is very important for the radiologist to recognize the abnormal findings on the MDCT or MRI studies for differentiating between medical and surgical cases of PCI.